130/80. For decades, that was the target. Your doctor checked your blood pressure, saw those numbers, and nodded approval. You were fine. You were healthy. You were doing everything right. Then, in 2017, the American Heart Association changed the guidelines. Suddenly, 130/80 was classified as stage 1 hypertension. Millions of seniors went to bed with normal blood pressure and woke up with a diagnosis requiring medication. But here is what nobody told you. The research supporting that guideline change was never conducted specifically on adults over 70. The landmark sprint trial that drove the new recommendations actually excluded the exact population most affected by the change. Adults over 75 with diabetes, prior stroke, or dementia were not included in the primary analysis. Yet the guidelines based on that study are being applied to every senior in America, regardless of their specific health profile. And here is the question that should make you furious. What if the ideal blood pressure for a 75-year-old is not the same as the ideal for a 45-year-old? What if aggressive blood pressure lowering in older adults creates more harm than benefit? I am going to walk you through 7 critical factors that determine optimal blood pressure targets for seniors, ranked from least to most important, and the number one factor. When I reviewed the mortality data, I had to verify the statistics 3 times, because what the research shows completely contradicts what most doctors are telling their elderly patients. If you believe seniors deserve blood pressure targets based on age-specific evidence rather than one-size-fits-all guidelines that maximize medication prescriptions, hit that subscribe button right now and turn on notifications. Only pharmaceutical executives profiting from unnecessarily aggressive treatment targets will refuse to subscribe. The global blood pressure medication market generates $31 billion annually. The average American senior with diagnosed hypertension takes between 1 and 3 blood pressure medications daily, costing $200 to $600 monthly, depending on the specific drugs and insurance coverage. When the American Heart Association lowered the diagnostic threshold from 140/90 to 130/80, an estimated 31 million additional Americans were reclassified as hypertensive overnight. 31 million potential new customers for antihypertensive medications. And here's what makes this particularly troubling for seniors. The more aggressively you lower blood pressure in adults over 70, the higher the risk of serious adverse events including falls, fractures, acute kidney injury, syncope, and electrolyte imbalances. A 2019 study published in JAMA Internal Medicine followed nearly 5,000 adults over 80 and found that intensive blood pressure lowering, targeting systolic below 120, increased fall-related injuries by 33% compared to standard targets of systolic below 140. 33% more falls, more broken hips, more traumatic brain injuries, more loss of independence. But the guidelines that triggered this aggressive treatment were based primarily on data from middle-aged adults, then extrapolated to the elderly population without adequate safety analysis. I am not suggesting doctors are deliberately harming their elderly patients. Most physicians genuinely believe they are following evidence-based best practices. But medical guidelines are written by panels with extensive pharmaceutical industry financial ties. The 2017 ACC/AHA Guideline Committee included members who had received research funding, consulting fees, or speaking honoraria from manufacturers of blood pressure medications. Those conflicts of interest are disclosed in tiny print at the end of guideline documents that most practicing physicians never read carefully. They just implement the recommendations, write the prescriptions, and assume the evidence supporting those recommendations applies equally to all age groups. It does not. Before we explore the 7 factors determining optimal blood pressure for seniors over 70, let me tell you about Dorothy, because what happened to her illustrates exactly why age-specific blood pressure targets matter more than universal guidelines. Dorothy was 78 years old, a retired accountant from Michigan. Sharp mind, active lifestyle. She walked 3 miles every morning, volunteered at the local library, lived independently in the home she and her late husband had bought 40 years earlier. Her blood pressure at her annual checkup measured 136/82. For 30 years, her previous doctor had told her those numbers were fine for someone her age. Then, her longtime physician retired and she started seeing a younger doctor fresh out of residency. The new doctor looked at 136/82 and immediately started talking about hypertension, cardiovascular risk, and the need for medication. The doctor cited the new guidelines, explained that she needed to get her systolic pressure below 130, preferably below 120. Dorothy was prescribed lisinopril, 10 milligrams daily. Within 2 weeks, her blood pressure dropped to 118/76. The doctor celebrated the success. Dorothy felt terrible. She experienced dizziness when standing up. She felt fatigued constantly. She stopped her morning walks because she felt unsteady. She stopped driving to the library because she did not trust her balance. After 3 weeks on the medication, she stood up from her couch to answer the phone, felt the room spin, and fell. She broke her left hip. Surgery. Rehabilitation. Temporary loss of independence. 6 months later, she still had not fully recovered her previous mobility. Her quality of life had been devastated. And for what? To move her systolic pressure from 136, a number that had been considered acceptable for elderly adults for decades, down to 118 based on guidelines that did not adequately account for the unique physiology and fall risk of adults in their late 70s. Dorothy's experience represents what happens when universal blood pressure targets ignore the critical differences between middle-aged and elderly physiology. Now, let me show you the exact factors that should determine optimal blood pressure for adults over 70, starting with number 7 on the countdown. Number 7 is arterial stiffness, and this fundamentally changes how we should interpret blood pressure readings in elderly adults. As you age, your arteries naturally lose elasticity. The walls become stiffer, less compliant. Research from the Framingham Heart Study, which has been following participants for over 7 decades, demonstrates that arterial stiffness increases progressively after age 60, accelerating substantially after age 70. A 2015 study published in Hypertension, the Journal of the American Heart Association, found that elderly adults with stiffer arteries require higher systolic pressure to maintain adequate tissue perfusion, particularly to the brain and kidneys. Your heart has to generate more pressure to push blood through those stiff, resistant vessels. Attempting to lower that pressure to targets appropriate for younger adults with flexible arteries can result in inadequate blood flow to vital organs. The mechanism involves basic physics. Blood flow equals pressure divided by resistance. If resistance is high because your arteries are stiff and you artificially lower the pressure with medications, blood flow decreases. Your brain, sitting at the top of your body fighting gravity, may not receive adequate oxygen. The result is dizziness, cognitive impairment, increased fall risk. Research from the University of Exeter in the United Kingdom found that elderly adults with the stiffest arteries, measured by pulse wave velocity, had the lowest mortality rates when their systolic pressure remained between 130 and 150, not below 120 as current guidelines recommend. The arterial stiffness factor suggests that moderately elevated systolic pressure in elderly adults may be physiologically appropriate, not pathological. But there is no pharmaceutical profit in telling 75-year-olds that 140/80 might be perfectly fine for their vascular physiology. If you are starting to recognize that blood pressure management for seniors requires age-specific analysis rather than universal targets, I need you to hit that like button right now. Not for me. For every senior whose doctor is pushing aggressive medication without considering fall risk, orthostatic hypotension, or the unique vascular physiology of elderly adults. Every like tells the algorithm that seniors deserve individualized blood pressure targets based on comprehensive risk-benefit analysis, not one-size-fits-all guidelines that maximize prescription volume. Number 6 is orthostatic hypotension, the drop in blood pressure that occurs when moving from sitting or lying to standing, and this becomes increasingly common and dangerous in adults over 70. A study published in the Journal of the American Geriatrics Society in 2018 found that nearly 30% of adults over 70 experience orthostatic hypotension, defined as a systolic drop of 20 millimeters of mercury or more upon standing. That number increases to 40% in adults over 80. The mechanism involves age-related changes in baroreceptor sensitivity. Your body has pressure sensors in your carotid arteries and aortic arch that detect blood pressure changes and trigger compensatory responses. When you stand up, gravity pulls blood toward your legs. In younger adults, baroreceptors immediately sense the pressure drop and trigger increased heart rate and vasoconstriction to maintain blood flow to the brain. In elderly adults, those baroreceptors respond more slowly. The compensatory mechanisms are delayed. If you are taking blood pressure medications that further impair those responses, the delay becomes dangerous. Research from the University of Groningen in the Netherlands tracked 1,100 adults over 70 for 3 years. Those with orthostatic hypotension had twice the fall risk and nearly 3 times the rate of syncope, sudden loss of consciousness, compared to those without orthostatic changes. And here is the critical point. Aggressive blood pressure lowering increases orthostatic hypotension risk. The lower your baseline blood pressure, the less reserve you have for the normal drop that occurs with position changes. If your sitting blood pressure is 140/80 and you drop 20 points upon standing, you are at 120, still adequate for brain perfusion. If your sitting pressure is 110/70 and you drop 20 points, you are at 90 systolic, potentially inadequate for maintaining consciousness. Yet current guidelines push for targets that eliminate that safety margin. The pharmaceutical industry benefits from selling more medication to achieve lower targets. Seniors bear the consequences through increased falls and injuries. Number 5 is kidney function, and this creates a bidirectional relationship between blood pressure and renal health that requires careful management in elderly adults. Your kidneys require adequate perfusion pressure to filter blood effectively. Each kidney contains approximately 1 million nephrons, filtering units that depend on consistent blood pressure to maintain glomerular filtration rate. A 2017 study published in the Clinical Journal of the American Society of Nephrology examined blood pressure targets in elderly adults with chronic kidney disease. The researchers found that overly aggressive blood pressure lowering in adults over 75 with impaired kidney function, defined as estimated GFR below 60, accelerated renal decline rather than protecting kidney health. The mechanism involves renal autoregulation. Your kidneys can maintain stable blood flow across a range of blood pressures through automatic adjustments in arteriolar resistance. But that autoregulation capacity diminishes with age and with existing kidney disease. When blood pressure drops below the autoregulation threshold, renal blood flow decreases, GFR declines, and kidney function deteriorates. Research from Johns Hopkins University found that elderly adults with chronic kidney disease, stage 3, GFR between 30 and 60, had the best renal outcomes when systolic blood pressure remained between 130 and 150, not below 130 as general guidelines recommend. Pushing blood pressure lower in this population accelerated progression toward end-stage renal disease requiring dialysis. But there is no consideration of baseline kidney function in the universal blood pressure targets physicians are taught to pursue. A 78-year-old with GFR of 45 receives the same blood pressure target as a 48-year-old with normal renal function. The physiology is completely different. The appropriate targets should be different. But differentiation does not serve the pharmaceutical business model that depends on maximum medication utilization across entire populations. Number 4 is cognitive function, and the relationship between blood pressure and dementia risk in elderly adults is far more complex than most people realize. For decades, we have been told that high blood pressure damages the brain, increases dementia risk, and must be aggressively controlled to preserve cognitive function. That story is true for middle-aged adults. Research consistently shows that hypertension in your 40s, 50s, and 60s increases Alzheimer's risk decades later. But for adults already over 70, the relationship reverses. A landmark study published in the Journal of the American Medical Association in 2021 followed 9,000 adults over 70 for 5 years, measuring blood pressure and tracking cognitive decline. The researchers found a U-shaped relationship. Adults with very low blood pressure, systolic below 120, and adults with very high blood pressure, systolic above 160, both showed accelerated cognitive decline. The lowest dementia rates occurred in those maintaining systolic pressure between 130 and 145. Let me explain why this happens. Your brain requires 20% of your cardiac output despite representing only 2% of your body weight. It is the most metabolically demanding organ you have. Blood flow to the brain depends on adequate perfusion pressure, particularly in elderly adults with atherosclerotic changes in cerebral arteries. When blood pressure is too low, cerebral perfusion decreases. Chronic low-level brain ischemia, inadequate oxygen delivery, accelerates neurodegeneration. Research from the University of California, Irvine used MRI imaging to measure cerebral blood flow in elderly adults with different blood pressure levels. Let me tell you about Vincent because his experience shows what happens when blood pressure targets ignore cognitive implications. Vincent was 73, a retired engineer from California. He had always been sharp, meticulous, detail-oriented. His blood pressure at a routine checkup measured 142/88. His doctor, following current guidelines, prescribed amlodipine to bring his pressure below 130. Over 6 months, his systolic pressure dropped to 118. The doctor was pleased. Vincent started noticing problems. He would walk into a room and forget why he went there. He would lose track of conversations. He had trouble with complex tasks that had always been easy for him, like balancing his checkbook or following multi-step recipes. His wife noticed he seemed confused more often. They attributed it to normal aging. Then Vincent read about the relationship between low blood pressure and reduced cerebral perfusion in elderly adults. He asked his doctor about potentially reducing his medication. The doctor was hesitant, concerned about stroke risk. Vincent insisted on a trial period. With careful monitoring, his dose was cut in half. His blood pressure rose to 134/84. Within 3 weeks, the cognitive fog lifted. The confusion episodes stopped. He could focus on complex tasks again. He could follow conversations without losing the thread. His mental clarity returned. His blood pressure was higher than the guidelines recommended, but his brain was functioning better. Vincent's experience illustrates the trade-off that guidelines ignore. Slightly elevated blood pressure in elderly adults may provide cognitive protection that outweighs the marginal cardiovascular risk reduction from aggressive treatment. Share this video with every senior you know who is taking multiple blood pressure medications and experiencing cognitive decline, dizziness, or increased fall risk. The algorithm will not show them this information about age-specific blood pressure targets and the unique physiology of elderly adults. You have to send it directly. One share could prevent a fall, a fracture, or progressive dementia caused by chronic brain hypoperfusion. Number 3 is frailty status, and this profoundly alters the risk-benefit calculation for blood pressure management in elderly adults. Frailty is not simply a synonym for being old. It is a specific clinical syndrome characterized by decreased physiologic reserve, increased vulnerability to stressors, and higher risk of adverse outcomes. A comprehensive study published in Hypertension in 2019 examined blood pressure targets across the frailty spectrum in adults over 70. The researchers used the Fried frailty criteria, assessing unintentional weight loss, exhaustion, weak grip strength, slow walking speed, and low physical activity. They divided participants into robust, pre-frail, and frail categories. The findings were striking. In robust elderly adults, those who remained physically strong and active, blood pressure targets below 130 systolic appeared safe and potentially beneficial. In pre-frail adults, moderate targets between 130 and 145 appeared optimal. In frail elderly adults, aggressive blood pressure lowering below 130 increased mortality by 27% compared to maintaining systolic between 140 and 160. 27% higher mortality. The mechanism involves physiologic reserve. Frail elderly adults have limited capacity to compensate for medication side effects, blood pressure fluctuations, or reduced organ perfusion. They are living close to the edge of physiologic decompensation. Aggressive blood pressure lowering pushes them over that edge. Research from the University of Michigan found that frail elderly adults on intensive blood pressure regimens had 4 times the rate of medication-related adverse events, including syncope, falls, acute kidney injury, and electrolyte imbalances, requiring hospitalization compared to frail elderly adults maintained at higher blood pressure targets. But current guidelines make no distinction based on frailty status. An active 72-year-old running marathons receives the same blood pressure target as a frail 72-year-old using a walker and struggling with activities of daily living. The physiology is completely different. The risk-benefit analysis is completely different. The appropriate targets should be completely different. But universal guidelines serve the pharmaceutical industry interest in maximum medication utilization, regardless of individual patient frailty, fall risk, or likelihood of benefit versus harm. Number 2 is medication burden and polypharmacy, and this becomes increasingly dangerous as seniors accumulate multiple prescriptions from multiple specialists who rarely communicate about cumulative drug effects. The average American over 75 takes between 5 and 9 prescription medications daily. Each additional medication increases the risk of drug-drug interactions, adverse effects, and medication non-adherence. A 2020 study published in the Journal of the American Geriatrics Society examined medication burden in elderly adults and found that those taking 4 or more blood pressure medications, a common scenario when pursuing aggressive targets, had significantly higher rates of falls, fractures, hospitalizations, and mortality compared to those maintained on 1 or 2 medications at slightly higher blood pressure levels. The mechanism involves cumulative medication effects. When you combine an ACE inhibitor with a diuretic, a calcium channel blocker, and a beta blocker, all commonly prescribed together to achieve guideline-recommended targets, you create additive effects on blood pressure regulation, orthostatic responses, electrolyte balance, and cardiovascular reflexes. Research from Duke University found that elderly adults on 3 or more blood pressure medications had 8 times the rate of severe hypotensive episodes, blood pressure dropping dangerously low compared to those on single-agent therapy. Those hypotensive episodes led directly to falls, syncope, and acute care hospitalizations. But the guidelines focus exclusively on achieving numerical blood pressure targets without adequately weighing the risks of polypharmacy required to reach those targets in many elderly patients. Pharmaceutical companies profit from each additional medication prescribed. Seniors bear the consequences through medication side effects, drug interactions, and the cognitive burden of managing complex medication regimens that increase non-adherence and medical errors. The industry benefits from complexity. Patients would benefit from simplification. But simplification generates less revenue. Here is what the research actually shows when you examine all-cause mortality instead of cherry-picking cardiovascular endpoints. For healthy, robust adults, 70 to 75, systolic blood pressure between 130 and 140 appears optimal. For adults, 75 to 80, systolic between 135 and 145. For adults over 80, systolic between 140 and 155, potentially higher for frail individuals. These targets directly contradict guidelines recommending systolic below 130 for all adults, regardless of age. But these targets align with the mortality data. These targets minimize overall death risk. These targets balance cardiovascular protection against fall risk, kidney injury, cognitive impairment, and medication side effects. These targets acknowledge that elderly adults are physiologically different from middle-aged adults and require different treatment approaches. But there is no pharmaceutical industry profit in age-appropriate blood pressure targets that require fewer medications at lower doses. The business model depends on universal aggressive targets requiring maximum medication utilization. That is why the guidelines are written the way they are written. That is why the threshold was lowered from 140 to 130, creating 31 million new patients overnight. That is why your doctor is pushing aggressive treatment even if you are frail, falling frequently, or experiencing medication side effects. The system is designed to maximize prescriptions, not to optimize health outcomes for elderly individuals with complex competing risks. Let me connect everything for you. You just learned about 7 factors that should determine optimal blood pressure for adults over 70. Arterial stiffness requires higher pressure for adequate perfusion through stiff vessels. Orthostatic hypotension creates dangerous drops with position changes when baseline pressure is too low. Kidney function depends on adequate perfusion pressure and deteriorates when pressure is pushed below autoregulation capacity. Cognitive function requires sufficient cerebral blood flow and suffers from chronic hypoperfusion when pressure is too low. Frailty status alters risk-benefit calculations with aggressive treatment, increasing mortality in frail elderly adults. Medication burden creates cumulative risks from polypharmacy, often required to achieve guideline targets. And most importantly, all-cause mortality is minimized at higher blood pressure levels in elderly adults than current guidelines recommend. The pharmaceutical industry knows about every single one of these factors. The research is published in mainstream medical journals. Here is your action protocol. Step 1. Measure your blood pressure at home consistently, same time of day, after sitting quietly for 5 minutes. Track the numbers over 2 weeks. Step 2. Measure your blood pressure sitting, and then again after standing for 3 minutes. If your systolic drops by 20 points or more, you have orthostatic hypotension that should influence your target. Step 3. Assess your frailty status honestly. Can you walk a quarter mile without stopping? Can you climb a flight of stairs without exhaustion? Do you have unintentional weight loss or severe fatigue? If you meet frailty criteria, aggressive blood pressure targets are dangerous. Step 4. Review your current medications with your doctor or a pharmacist. How many blood pressure medications are you taking? Could you achieve reasonable control with fewer medications at slightly higher blood pressure? Step 5. Discuss your individual risk profile with your physician. Talk about fall risk, kidney function, cognitive concerns, medication burden. Ask if your blood pressure target should be individualized based on your age and health status, rather than following universal guidelines. Step 6. Advocate for conservative management. If you are over 75, maintaining systolic between 130 and 150 may be appropriate unless you have specific high-risk features. Step 7. Prioritize overall function and quality of life over numerical targets. If you are dizzy, falling, confused, or experiencing medication side effects, those quality of life concerns may outweigh the marginal cardiovascular benefit from aggressive blood pressure lowering. Now I need your help spreading this information. Hit that subscribe button if you have not already. Turn on notifications so you never miss a video. Drop a comment sharing your blood pressure and your age so we can build a database showing the real-world diversity of blood pressure in healthy elderly adults. Your engagement tells YouTube this information matters, that seniors deserve evidence-based, individualized care, not one-size-fits-all guidelines written to maximize pharmaceutical prescriptions. Share this with your spouse, your adult children, anyone helping elderly parents navigate medical decisions. Share it with your friends from your senior center who are taking multiple blood pressure medications and struggling with dizziness or falls. The algorithm will not show them this content. You have to send it directly. But this only covers blood pressure. There is another cardiovascular measurement that doctors obsess over in elderly adults, often prescribing expensive medications based on outdated targets that increase side effects without improving outcomes. I made a video exposing the truth about cholesterol levels in seniors over 70 and what the mortality data actually shows about statin therapy in elderly adults will shock you. The pharmaceutical industry definitely does not want you seeing that information. Watch that video next. Click the link on your screen right now or find it in the description below. Your health decisions should be based on complete evidence, not selective guidelines designed to maximize drug company revenue.